All right, hi guys, good evening or good afternoon rather. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Quick feedback. Okay, so today we'll be talking about the salivary glands. Okay, so we'll talk about all the important topics that they ask you in salivary glands. We'll do a quick succession as well as a quick recap as well. Just give me a second. All right, so I think that's better now. But we'll try to finish the salivary glands. The session will last for maximum 2 to 3 hours, and we'll try to wrap everything which is important for salivary glands here. Now, when you talk about the salivary glands, a quick component about how we are going to go about it. So when you take the salivary glands into consideration, now when we discuss salivary glands, two important things in the salivary glands in terms of discussion. Number one, I can divide the salivary glands into two categories. One is your major salivary glands, and other one is your minor salivary glands, right? So we have the major salivary glands and the minor salivary glands. Major salivary glands are usually the paired glands, and the minor ones are quite small, so they cannot be literally named, they can be numbered. Now we talk about the major salivary gland. The major ones that you have is your parotid gland. This is going to be the parotid gland. Then you have the submandibular gland, parotid gland, the submandibular gland, and the sublingual gland. So you have the parotid gland, the submandibular, and the sublingual gland. These are the three pairs of the major salivary glands that you have. The minor salivary glands do not have a number, but I can tell you there are approximately 800 minor salivary glands. And one problem is, remember, minor salivary glands, if they develop into into neoplasia, they're usually malignant. So more dangerous is your minor salivary gland tumors when compared to major salivary gland tumors, right? Just for the sake of objective, if you take this as a representation of the patient, this is the head and neck. Let's say this happens to be the ear that you have. And let's say this happens to be the neck. This goes into thorax, right? This is the orbit, and let's say this is the zygomatic arch. That's the zygomatic arch, right? Now, the salivary glands that you can see across here. The salivary glands that you will see here, there's one salivary gland which is present here in this area. There's one that is going to be present in this area, and one that is if you take this as a representation of the oral cavity, and let's say this happens to be the tongue. On the under surface of the tongue, you have another one. This is your sublingual, right? So three major salivary glands that we are going to label it down. This is what we call it as the parotid gland. This is what we call it as the parotid gland. This is what we have the submandibular gland. This is your submandibular gland, and this happens to be your sublingual gland. This happens to be sublingual gland. So these are the paired salivary glands that you have, right? Beta, this is going to be helpful for NEET PG also. Obviously, for university exams, I'm going to give it more like a structured exam writing answer pattern, but the facts and the concepts will remain the same, right? We'll go a little bit faster. That's the only thing that we do a little bit different here. So these are the salivary glands that we're going to talk about it. So when you talk about the parotid gland, quickly running through the anatomy of the parotid gland. So we'll talk about the anatomical orientation of that of the parotid gland. Now, just for the sake of understanding, let's say this happens to be the zygomatic bone and this is the mandible that is present, right? So this is the mandible that is present, right? This happens to be the zygomatic arch that you have, right? Just for the sake of understanding, this is the mandible that we're talking about. That's the zygomatic arch that is present, right? Between this mandible, which is present here, this is the angle of the mandible, and superiorly you have the zygomatic bone. You have your parotid gland, which is going to be positioned here. So this is where the parotid gland is going to be present. So this is the location of the parotid gland. This is the location of the parotid gland, right? Now you will notice there is a muscle which is going to be running behind the parotid gland, in which the parotid gland is going to rest. So this is a muscle that is running on the posterior surface of the parotid gland, and we say the parotid gland is basically resting on this muscle. Any idea what is this muscle? On which muscle? So there is this vertical oriented muscle that is going to be present, right? So the muscle on which the parotid gland is going to sit. What is this muscle? The muscle on which it is going to sit, this is what we call it as the masseter, right? So the parotid gland is going to be having this, the masseter muscle. So two important muscles which are going to be present. One is going to be masseter. Another one, if you look at, this is the opening of the mouth. I'll just say it across here. There's another muscle which is going to run horizontally. There's another set of muscle which is going to run horizontally, right? So there's another muscle which is going to run horizontally. There's one vertical muscle, another one, there's a horizontal muscle which is running. And then you see the teeth that is going to be present. So just for the sake of understanding, these are the teeth that are present. It's going to be the molars that are present. Let's say, just for the sake of understanding, I'm just showing you the oral cavity and the mouth which is present, right? You will notice that the parotid gland which is present on the anterior surface of this muscle. So the two muscles which we have drawn here. The first muscle is what we call it as the masseter muscle. This is what we call it as the masseter muscle, which is there in the brown which we have depicted. Another muscle that you have is going to be your buccinator muscle. So another muscle that is present here, this is your buccinator muscle. This is your buccinator muscle. So you have the masseter muscle and the buccinator muscle, and then you have the parotid gland which is going to be present here. Manipal is a survey which is better for profs. So survey becomes extremely easy. What about the general survey? But general surgery we've already completed. There are lectures. We'll pin you in the group. You can go watch it again, right? Let's finish this. Let's concentrate, because salivary glands is something which you usually don't see in your clinics also or in the hospitals. So thoda tricky hai. So we'll try to decode it. So let's not get distracted while this lecture. So parotid gland जो present है, it is here under the zygomatic arch in front of your mandible, and it rests on two muscles. पीछे जो muscle है वो आपका masseter है, और जो transverse जा रहा है उसको आप buccinator बोलते हो, right? Now you will notice there is a duct that is going to arise. The duct is going to arise from the parotid gland. It is going to arise from the parotid gland. It is going to run over the masseter. It goes into the buccinator muscle. It pierces the buccinator muscle. It is going to pierce the buccinator muscle, and then it is going to open onto the crown of the second molar. It is going to open onto the crown of the second molar. So this duct which you are seeing, this is nothing but your parotid duct, right? So the duct that you're going to see, this is what we call it as the parotid duct, or also called as the Stensen's duct. This is what we call it as the Stensen's duct. Stensen's duct is the duct which is also called as the parotid duct, which is going to go. Now here see the passage of this Stensen's duct is very important. Now if you see very carefully, it is going to pass two muscles, right? Now what are the two muscles that it is going to pass through? Superiorly, you have the zygomatic arch which is present. So this is the zygomatic arch that is present across here, right? So this is the entire zygomatic bone that is going, right? Now you notice that this duct, which is your Stensen's duct, is going to present, or it is going to pass through the two muscles, right? Stensen's duct is going to run over. The Stensen's duct is going to run over the masseter. It runs over the masseter muscle. It runs over the masseter muscle and it pierces the buccinator muscle. It is going to pierce, or it is going to puncture through, it is going to pierce through the buccinator muscle. It is going to pierce through the buccinator muscle. So it runs over the masseter. That is why when we ask you to clench the teeth, now you make your masseter tight and then you'll be able to feel the duct. Where do you feel the duct? It is exactly around 1 to 2 centimeters below the inferior border of the zygomatic arch. So if I take it across here, approximately 1 to 2 centimeters from here to here, it is around 1 to 2 centimeters. It is 1 to 2 centimeters below the inferior border of the zygomatic arch. You will be able to feel your Stensen's duct. You will be able to feel your Stensen's duct. So parotid gland is sitting over the masseter. The parotid duct, which is now, as you can see, it is going to go and open onto the opening of the Stensen's duct. The opening of Stensen's duct is present over the crown of the second molar or upper molar tooth. The crown of the second upper molar tooth is what you will see the parotid opening or duct opening is being present, right? Now, when you look at the parotid gland per se, if you evaluate the parotid gland, it has got two lobes. It is what superficial lobe of the parotid gland, and then there is the deep lobe of the parotid gland. So there are two lobes of the parotid gland. They're superficial and deep. Now, what is interesting is this is something that we have divided it, naturally, anatomically. There is nothing called as superficial or deep. So how do you know that which part of the parotid gland is superficial and which part of the parotid gland is deep? You will follow the neurovascular bundle. Now the neurovascular bundle is, you will see there's an artery. There's going to be an artery that is going to run through it. Under the artery you have the vein. And below the vein you have the nerve. Right? This is what we call it as the neural bundle or the arteriovascular bundle that is present. So what is this artery that you're looking at? Now the artery that you're looking at, this is going to be your, which again a very, very important concept. This they have asked you multiple times. What is the vessel that divides the parotid gland into superficial and deep? Remember, it is your external carotid artery. This is your external carotid artery. Many a times we give you a wrong answer as facial artery. No, facial artery is going to be here. It does not cross us here. This is your external carotid artery which is going to go. Then you see there is a vein that is present. This is your retromandibular vein. This is your retromandibular vein. This is your retromandibular vein. And the most important nerve that you see here, this is your facial nerve. The seventh cranial nerve that you have, this is your facial nerve. You can see all these three components, which are nothing but we call it as the neurovascular plane that is present. This is what we call it as the fascio-venous plane of Fatty's. This is what we call it as the fascio-venous venous. It is the fascio-venous plane of Patey's. This is what we call it as the fascio-venous plane of the Patey's, which divides the parotid gland into two subsets. That is nothing but the superficial lobe. This is what we call it as the superficial lobe of the parotid gland, and this is the deep lobe of the parotid gland. So the division of superficial and deep is because of this neurovascular bundle that is present. It is by the external carotid artery, then you have retromandibular vein, and then you have the facial nerve. Any part of the gland which is present above this is superficial parotid lobe, and anything which is beyond this or deeper to this is what we call as the deep lobe of the parotid gland. Okay. Now this is how you see the parotid gland which is going to present. Now you will notice that the entire parotid gland is going to be covered by a capsular layer, and this capsular layer which is going to cover is what we call it as the true capsule. This is what we call it as the true capsule of the parotid gland. Now on the superficial layer you see there is a capsule that is present. This is what we call it as the pseudo capsule. This is what we call it as the pseudo capsule of the parotid gland. So parotid gland consists of two capsules which are going to be present. Number one, you have the true capsule. Number one is what we call it as the true capsule. Remember, true capsule is going to be present throughout the parotid gland. It is very densely adherent to that of the parotid gland. It is inseparable. And the outer one is what we call it as the pseudo capsule. The outer one is what we call it as the pseudo capsule of the parotid gland. The outer one is what we call it as the pseudo capsule of the parotid gland. Remember, if you have seen my thyroid lecture, we tell you there's a fascia that is covering the thyroid gland. No, that is nothing but investing layer of deep cervical fascia. The pseudo capsule of the parotid gland is also derived, or it is also from the investing. This is also from the investing layer of deep cervical fascia. It is also from the investing layer of the deep cervical fascia. It is also from the investing layer of the deep cervical fascia, which is called as the pseudo capsule of the parotid gland. This is what we call it as the pseudo capsule of the parotid gland. Remember, the true capsule of the parotid gland is densely adherent to that of the parotid gland. It is inseparable. It is inseparable from the parotid gland. It is inseparable from the parotid gland. Now, this is the basic orientation of the parotid gland that you should be aware of. Another gland that you should be aware of is going to be a submandibular gland. We'll quickly run through the submandibular gland also. Now, when you look at the submandibular gland, the name itself saying it is under the mandible, which is going to be here. This is your submandibular gland, or the gland which is present just under the mandible. This is what we call as submandibular gland. Now, where do you see the submandibular gland? When you evaluate this, now this is the mandible, this is the angle of the mandible that you have. Let's say this is how the mandible is being depicted. I'm showing you on one particular end, right? Now, if you look at from the lateral view, you will see that under the mandible the bone that is present here in the midline is going to be the hyoid bone. Let's say this is the depiction of the hyoid bone that is present here. So this is the hyoid bone that is present. This is the hyoid bone that is there. Then you have the mandible. This is the mandible that is present. Between the mandible and the hyoid bone, there is a muscle that is going to run. This is called as the mylohyoid muscle. The muscle which is running here is what we call it as the mylohyoid muscle. The muscle that you are seeing here is your mylohyoid muscle. From the inferior border of the mandible to that of the hyoid bone, from the inferior border of the mandible to the hyoid bone, the muscle that is present here, this is going to be your mylohyoid. Now, you will see our submandibular gland that is present. The submandibular gland is going to be present around this muscle. So, it will cover the anterior surface here. It is going to be the anterior surface, and then there is a posterior extension. It is going to be present on the posterior surface of the muscle also. So, it hugs the muscle like this. If this is the muscle, This is how the gland is present. So this is the anterior surface, this is the posterior surface. Okay? It's going to hug like this. It goes like this, it goes like this, right? So it's like a C loop that is present. This is where the submandibular gland is going to be present, right? So this is your inferior border of the mandible. This is the inferior border of the mandible. This is the inferior border of mandible. This happens to be the mylohyoid. This happens to be this mylohyoid muscle. This happens to be the hyoid bone. This happens to be the hyoid bone, and this is your submandibular gland. This is your submandibular gland. This is your submandibular gland. Now, when you depict the submandibular gland, same thing. If I just isolate the muscle and then I show it to you. Now, if you take this as a representation of the muscle, which is your mylohyoid muscle that is present. I'm just showing you the mylohyoid muscle. Let's say this is the mylohyoid muscle that is present. This is the mylohyoid muscle that is present. And you would notice the submandibular gland has two surfaces, or I can say two lobes rather. One is going to be your superficial, another one is going to be deep. One that is present here, this is your superficial, and then it is going to go arch like this, right? So this is how it is going to be present. So the one that is present on the anterior surface. This is the posterior surface that you have, and this happens to be the anterior surface of the submandibular gland. Now, if this is the one that is present on the above surface, this is what we call it as, the superficial lobe, right? So rather, if you just put it across here, this is how it is going to present. The one that is present here, it is the superficial lobe, and behind that is going to be a deep lobe. All right. So this is your superficial lobe. This is the superficial lobe of the submandibular gland, and the one that is present here, this is the deep lobe. This is the deep lobe of the parotid gland, submandibular gland. This is your submandibular gland. This is your submandibular gland, and this is your mylohyoid muscle. This is your mylohyoid muscle. This is your mylohyoid muscle, right? So this is the orientation of the submandibular gland that you need to have, that how the submandibular gland is going to be depicted, what is its objective in submandibular gland, what is the location in general. Now, one of the most important aspect is how the secretions of the submandibular gland is going to open into the oral cavity, right? Now, just to give you a perspective out of it, again, we'll take this as a representation of the mandible, just for the sake of understanding. This, let's say the hyoid bone is present. This is the orientation of the hyoid bone. Let's say this is the hyoid bone that is present here. Let's say the muscle that is present between these two is here. This is your mylohyoid muscle. This is the mylohyoid muscle that is present. This is the mandibular or the inferior border of the mandible that is present across here. Just for the sake of understanding, let's say this is the tongue that is present, or I can say this is the lingular aspect. This is the lingular or the tongue that is present, and I'm depicting you the undersurface of the tongue. right? So this is the tongue that is present, or I can say this is the lingular component that is present. Now you will notice there's a gland that is present under the tongue. This is what we call it as the sublingular gland. This is the sublingular gland is present. And here you have the gland, which is going to be your submandibular gland. So this is where our submandibular gland is present. This is how the submandibular gland is going to be present. This is how the submandibular gland is present. So submandibular gland is there, lingual gland or sublingual gland is present, right? Now you will notice from the deep lobe, that is from the posterior surface, there's a duct that is going to arise. The duct that arises from the deep lobe is what we call it as the Wharton's duct. Now this Wharton's duct is now going to go from here. It travels into the oral cavity. It is going to pierce here. As it travels across here, it reaches all the way to that of your sublingual glands. Now from the sublingual gland, it will give rise to the sublingual ducts. There are smaller sublingual ducts are present. Now these small sublingual ducts together, they combine to form one duct, which is going to be the sublingual duct. Now this sublingual duct is combining with that of the submandibular glands duct, and they all open onto the under surface of the tongue. And this opening is what we call it as the lingular frenulum. This is what we call it as the lingular frenulum, right? Now, just to give an objective, the duct that arises from the submandibular gland is what we call it as the Wharton's duct. This is what we call it as the Wharton's duct. When the Wharton's duct combines with the sublingual duct together, they will now be called it as the Bartholin's duct. This is what we call it as the Bartholin's. This is what we call it as the Bartholin's duct, and all of them open together on the undersurface of the tongue. This is what we call it as the lingual frenulum or the lingual frenulum. You will see a lingual frenulum is present. Now, in this relation, you will see that the three important nerves which are going to be present. A nerve that is going to run on the inferior border of the mandible. The nerve that is running on the inferior border of the mandible is what we call it as the marginal mandibular nerve. So the nerve that runs here, this is what we call it as the marginal. This is the marginal mandibular nerve. This is what we call it as the marginal mandibular nerve. Along with that, you will see there's another nerve which is going to come from the posterior surface and just crosses at the Wharton's duct. That just crosses onto the Wharton's duct. This is your lingual nerve. This happens to be your lingual nerve, right? Then there is a nerve which is running on the posterior surface of the gland, and the nerve that is running on the posterior surface of the gland, this is what we call it as the hypoglossal nerve. This is what we call it as the hypoglossal nerve. This is what we call it as the hypoglossal nerve. Now, if you look at this, there are three nerves which are very closely associated with the submandibular gland. This is your submandibular gland. This is your submandibular gland, and this is your sublingual gland. This is your sublingual gland. Now, the three nerves which are closely associated with submandibular gland. Number one is the lingual nerve, then the marginal mandibular nerve, and the hypoglossal nerve. So, during the surgery of the submandibular gland, these are the three nerves which are usually associated with the risk of injury or the damage. The risk of injury or the damage, right? So, when you talk about the Wharton's duct, what are the important points to be remembered? Now, with respect to Wharton's duct, remember Wharton's duct is 5 centimeters in length. It is 5 centimeters in length. It arises from the deep lobe. It arises from deep lobe of the submandibular gland. SMG stands for submandibular gland. It is how does it enters into the oral cavity? It pierces the floor of the mouth. It is going to pierce, or it is going to perforate the floor of the mouth. It perforates the floor of the mouth. Now, if you look at this, a very peculiar thing, if the secretions are going to produce there, how are they going to go into the frenulum? They have to go up. So this is the only gland which will have the secretions but pumping in the direction opposite to the gravity. So it will have an anti-gravity drainage. This duct will have an anti-gravity drainage. This is going to have an anti-gravity drainage. It is going to have anti-gravity drainage. Now, very interesting thing about the lingual nerve. No, as the lingual nerve is going to go at this Wharton's duct, it is going to hook and then come back. It is going to hook and then come back. So, if you observe very carefully the lingual nerve forms a hook. It forms the hook, which is going to be around the Wharton's duct. Just to give you an objective, if this is the Wharton's duct, that you see, imagine if this is the Wharton's duct, the lingual nerve is going to come and then it is going to turn a hairpin loop. It just kinks the duct here. So duct is going to get compressed. This is because the lingual nerve which is present here. So this is what we call it as the hairpin loop. This is the hairpin loop of lingual nerve around the Wharton's duct. Around the Wharton's duct. So this is the lingual nerve that you can see here. This is the lingual nerve and this is the Wharton's duct. So around the Wharton's duct, it forms this hairpin loop. The problem is when it forms this loop, no, it is going to compress. It compresses this duct and the duct is going to get kinked. Now, what is the clinical relevance to it? So because of this hairpin loop, the secretions which are here, if you have to give the diagrammatic correlation, you can see the hairpin loop is formed here. So whatever secretions which are going to be produced, whatever secretions which are produced in this duct, if they are going to be pumped out, and because of this hairpin loop, they get compressed, so these secretions will start pooling. And when the secretions will start pooling within the duct, they will precipitate into development of stone, hence resulting in stone formation submandibular gland duct. In fact, one of the most common sites for the sialolithiasis, that is the stones in the salivary gland, is submandibular gland. Number one, because of anti-gravity drainage. Number two, it is because of this hairpin loop of the lingula. And number three, it is going to be because of thick viscous secretion which are rich in calcium. Okay? So this is with respect to the Wharton's duct, right? Now, if you talk about specifically about submandibular gland secretions, important points about the submandibular. It is about the submandibular gland secretion. With respect to the submandibular gland secretion. With respect to the submandibular gland secretion. So, when we talk about the submandibular gland secretion, what are the important points? Number one, they are thick and viscous secretions. They are thick and viscous secretions. They are thick and viscous secretions. They are rich in calcium. They are rich in calcium. They have an anti-dependent drainage. These secretions will have an anti-dependent drainage and there is increased stasis of secretion. Then increased stasis of secretion. So thick and viscous secretion, they're rich in calcium, there's an anti-dependent drainage and they increase the risk for stasis of the secretion, and that is why submandibular gland becomes one of the most common sites for the development of your sialolithiasis, right? That is salivary gland stones. Now, one question that you will see in exam again and again, and that is going to be your sialolithiasis. So start with the basic topic of sialadenitis and then we'll quickly talk about it. So we'll talk about the sialadenitis. Now, what is this sialadenitis? What do you mean by the sialadenitis? So when I say the word sial, that means the salivary glands. This is what we call it as the salivary glands. And when I say adenitis, it is the inflammation. The word adenitis is inflammation of the gland. So it is the inflammation of the salivary gland. The sil is basically salivary glands. Itis is inflammation. So basically it's an inflammation of the salivary gland, and that is what we call it as sialadenitis. Now, anywhere in the body, whenever we talk about any form of inflammation, we can categorize the inflammation into two groups. One, there will be an acute, another one, there will be a chronic inflammation. So same thing, the sialadenitis can also be divided into two categories. Number one is an acute sialadenitis, and number two, there is a chronic sialadenitis. There's an acute sialadenitis and a chronic sialadenitis. Now, when you look at the causes for the acute sialadenitis, so what results in acute sialadenitis? So, if I categorize them into cause, the cause for acute inflammation of the salivary glands can be divided, either it is going to be viral or it is going to be bacterial. Either it is usually viral or it is bacterial. Either it is viral or bacterial, whenever they say which is more common. Remember, the viral infections of the salivary glands are far more common. So hence the sialadenitis due to virus is more common when compared to bacteria. Now, what are the viruses which are associated with sialadenitis? We can remember with a small mnemonic. We call it as the CPSM. We call it as C. Your favorite subject is PSM. So I'm asking you to see PSM. I mean, if you don't see also, that is fine. But then majburi hai to dekhna padega. C stands for cytomegalovirus. P stands for the paramyxovirus. S stands for the Coxsackie virus. It is the Coxsackie virus. And M stands for mumps virus. So here your C is your cytomegalovirus, P is your paramyxovirus, S is your Coxsackie virus, M is your mumps virus, right? So whenever we talk about the viral infections, of the salivary gland, remember it is the most common site for sialolithiasis or the sialadenitis. It is the parotid gland. It is parotid more common when compared to submandibular. Parotid gland is more commonly involved when compared to submandibular gland. It is the viral form of infection which is more common when compared to the bacterial form. And the most common bacteria causing sialadenitis is a Staph aureus. The most common bacteria causing sialadenitis is your Staph aureus. It is going to be Staph aureus. So when we talk about the bacteria, as we have just discussed it, the most common bacteria causing this is going to be the Staph aureus. It is going to be Staph aureus. So these are the causes for your acute sialadenitis. It is an causes for acute sialadenitis. Somebody is asking, sir, Farre follow करके क्या मैं surgery pass हो जाऊंगा? बेटा distinction आ जाएगी, tension मत ले, है ना? But if notes are not available, what I'll do is, one will make sure it is available. Second, I'll also give you the Telegram QR code from where you can derive the notes soon after the class. We'll also post the link in the same lecture also. It happens. Okay? Chalo. Now, this is in the context of acute sialadenitis. So, what is the cause for chronic sialadenitis? So, we talk about the causes for the chronic sialadenitis. For the chronic sialadenitis, number one, it is the granulomatous cause. So the granulomatous cause for sialadenitis is tuberculosis. It is secondary to HIV as well. Gland abscess. Development of salivary gland abscess. Recurrent sialadenitis. It is a recurrent inflammation and secondary to radiation exposure, which is called as radiation sialadenitis. It is a radiation sialadenitis. So you have the granulomatous TB, HIV, gland abscess, recurrent sialadenitis, and radiation sialadenitis. So all these are the causes. All these are the causes for your chronic inflammation of the salivary glands. Right? Now, once you have known about these causes, let's try to decode each individual cause. We'll start with our short note, which is asked in the exam, which is about the parotid abscess. So when we talk about the parotid abscess, the parotid abscess is also commonly known as the suppurative parotitis. It is also called a suppurative parotitis. It is suppurative parotitis, right? Now, if you look at what is the cause for the parotid abscess, it is, as we have discussed, bacteria is more common than virus in parotid, right? The most common bacteria causing this is going to be Staph aureus. What is the route? How does this Staph aureus gets into the parotid gland? It is via the ascending bacterial parotitis. It is via the ascending route. It is via the ascending route. Now, what is this ascending route? How can a bacteria get into the parotid gland in an ascending route of formation? So, for this ascending route, to understand the ascending route, it usually occurs secondary to an obstruction. So, it is secondary to obstruction in your Stensen's duct, or also called as the parotid duct. Secondary to the obstruction in the parotid duct. Now, my question is, what can lead to the obstruction in the parotid duct? The causes for the obstructions are, number one, it can be because of malignancy. Number two, it can be because of poor oral hygiene. It can be because of the poor oral hygiene, post surgery, and it can also be because of decrease in secretions. Now, the causes that causes decrease in secretion. So, what will result in development of decrease in secretion? Now, decrease in secretion is seen in dehydration. It is seen in dehydration. It is seen in starvation. Dehydration, starvation, and sepsis. There are three conditions where you can have decreased secretions. Okay. So this is the secondary to obstruction of the parotid duct. Now, how would a patient of parotid abscess present to you? We'll talk about the clinical features. Again, nothing spectacular about it. Keep it very simple. You will understand it this particular way. At the end, it is inflammation, and anywhere in the body, if you're talking about inflammation, it will be associated with rubor, callar, dollar tumor. Wahi features aane yahan pe bhi same to same, right? So we see the usual age of presentation. The usual age of presentation for parotid abscess is seen between 40 to 60 years. It is seen between 40 to 60 years, more common in males when compared to females. And the most common risk factor associated with this is going to be diabetes mellitus. So these are more common in diabetic patients. These are more common in your diabetic patients, right? So how would the patient present to you? In general sense, obviously the patient is going to have inflammation, so there will be rubor, callar, dollar tumor. So all that features will start here, starting with the pain first, right? So the presence of severe pain, there is severe pain in parotid region. There is severe pain in parotid region. But how do you know it is the pain associated with the parotid gland or not? When the patient is going to eat, more amount of secretions are going to come out. Now, because parotid gland gets stimulated when you eat. Now, as the secretions will start to come more, the gland has to function more, and the gland irritation will happen, and that increased irritation of gland will aggravate the pain. So, one of the most important pickup point is the component of pain increases during eating. The component of pain increases during eating. So patient would rather not prefer eating at all. Along with that, it will be associated with fever. This is going to be associated with fever. And when you examine, there will be presence over redness over the gland. There will be presence of redness over the parotid region, or the gland is going to be present. Now, initial presentation is only this. So, clinical features will be pain, which increases during eating. There will be associated fever, redness over the gland. I would like, okay, bring it on. Let's examine. So, on examination, what are the findings that are going to see? Number one, the presence of severe tenderness. The patient won't let you touch the parotid gland. So, there is severe tenderness over the gland. There will be severe tenderness over the gland. Normally we say anywhere there is a collection of fluid, there should be presence of fluctuation sign. If you remember in our breast chapter, we discussed it very clearly that the parotid abscess will have a delayed positive fluctuation sign. So here there will be delayed fluctuation sign positive. There will be delayed fluctuation sign positive. Along with that, when you observe very carefully, there will be presence of pus or turbid discharge from the opening of the parotid duct. From the opening of parotid, duct. So that discharge, that pus which is going to pour out is going to be very evident from there onwards. Then you will see it will be presence of palpable. There is palpable and tender cervical lymph nodes. There's palpable and tender cervical lymph nodes. So there is a severe tenderness over the gland, delayed positive fluctuation sign, pus or turbid discharge from the opening of the parotid duct. There is palpable and tender cervical lymph nodes will be noticed. And so how do you evaluate? Remember, the investigation of choice for parotid abscess is going to be an ultrasound. Management depends upon what stage is the patient presented to us. If there is only acute inflammation, but no abscess is formed, in a state of acute inflammation, I'll go with conservative line of management. In the conservative line of management, I'll start the patient on antibiotics. Give analgesia. Hydrate the patient well, plus treat the underlying cause. That is if the patient is presented with acute inflammation. On the other hand, if it is now translated into an abscess, if this acute inflammation, if it is left untreated, it will now result in development of parotid abscess. Now, if the patient develops parotid abscess, then there is no if and but. Here you have to go with incision and drainage. You have to give incision and drainage. Incision and drainage with antibiotics. Right? So this is how you're going to manage your acute inflammation of the salivary glands in terms of parotid abscess, right? So every single thing that we have spoken about here is important. You have to do a quick recap. That should be more than enough with respect to Sialadenitis, that is your parotid abscess. So parotid abscess, it will come as a short note. You should be able to write all these important points. You don't need to write so elaboratively. You can write the causative agent, that is bacteria, is more common than virus. The most common is going to be Staph aureus. They talk about the clinical features. Remember, the most important is pain increases during eating and when the patient is masticating. On the other hand, on examination, there's tenderness is there, delayed fluctuation sign, investigation of choice is ultrasound, management, acute inflammation is conservative, abscess, it is going to be incision and drainage. That's it. If you write this much, it is more than enough. Next comes another important topic or a question that they will ask you. This is your sialolithiasis. This is what we call it as the sialolithiasis. This is what we call it as the sialolithiasis. So when I say sialolithiasis, the word again sialo means salivary glands. It is called as the salivary gland. The word lithiasis basically means stones. So we're talking about stones in the salivary gland. Now, when you talk about the stones of the salivary gland, one of the interesting things that you will notice is we've spoken about the gallstones. In the gallstones, we say that around 90% of them are radiolucent, 10% is radiopaque. In the nephrolithiasis, that is in kidney stones, which we spoke last week, we say 90% of them are radiopaque, 10% of them are radiolucent. The data here is slightly different. In the stones of the salivary gland, 80% of them are going to be radiopaque and 20% of them are going to be radiolucent. 20% of them are going to be radiolucent, right? So this is the concept of stones in sialolithiasis to be remembered. Now, when I say what is the most common site for these stones, we have already discussed it. The most common site for sialolithiasis is the submandibular duct. This is your submandibular duct, which is also called as the Wharton's duct. Also called as the Wharton's duct or the Wharton's duct stone. Now, why submandibular gland is more common? If you're still asking me, I am extremely worried because we have already discussed it. Why submandibular gland is going to be the most common site for development of the stones? It is because thick viscous secretion, rich in calcium, anti-dependent drainage, increased risk for stasis. All these goes in favor of development of these stones, right? All these goes in the favor of development of the stones. So hence the sialolithiasis will be formed here, right? Now when you talk about it, what is the composition of the stone? So whenever the stone is going to be formed, they'll ask for the composition of the stones which are developed here. The composition of the stones are calcium phosphate. They are the calcium phosphate and calcium carbonate. They are the calcium phosphate and the calcium carbonate. It's the calcium phosphate and the calcium carbonate. Now, how will a patient present to you? We talk about the clinical features of the sialolithiasis. So whenever there is a stone, whenever there is a stone in the salivary gland duct, it will present with chronic inflammation of the salivary gland. So they will present to you with chronic. So there are signs and symptoms of chronic sialadenitis. There are chronic sialadenitis. The present is chronic sialadenitis. There are features of chronic sialadenitis. So how will a chronic sialadenitis will present to you? Same thing, the patient will have pain. If it is in submandibular gland, in the submandibular gland, the pain in the submandibular gland. The presence of pain in the submandibular gland, and the component of pain is going to increase during eating. So this component of pain increasing during eating is constant or consistent for all the patients with your salivary gland lesions, or I can say the salivary gland pathology is usually associated with increase in pain during eating. So that is something which is going to be consistent, right? Now, along with that, you will notice the size of the swelling. The size of the swelling increases during eating. Increases during eating, and then it disappears in 2 to 3 hours. So swelling which is going to appear, this is going to appear during eating or increases during eating, and the swelling disappears. Swelling disappears 2 to 3 hours after eating. 2 to 3 hours after eating as well. After 2 to 3 hours of eating. Now, when you palpate this, it will appear to be firm and rubbery. The swelling will be firm and rubbery with tenderness. Now, because of inflammation, it will be painful while touching. The patient will also have pain in the tongue, and that is called as referred pain. So, patient is now going to have referred pain to tongue. The patient is going to have referred pain to tongue. This is because of involvement of the lingual nerve. It is because of involvement of the lingual nerve, right? It is firm, rubbery and tenderness. It is going to have a referred pain, and that referred pain is because of irritation of lingual nerve. We know the lingual nerve is going to take an arch around the Wharton's duct, and because whenever this duct is going to get irritated, it will irritate the lingual nerve. Irritation of lingual nerve will cause referred pain to tongue, and hence that is going to be present as well, right? Now, this is with respect to sialolithiasis. Now, sometimes you can have a patient with multiple stones. The presence of multiple stones associated with chronic inflammation of submandibular gland, of the submandibular gland. It is going to be associated with the chronic inflammation of the submandibular gland, right? Now, this stones which are causing chronic inflammation of the submandibular gland will be associated with a condition which is called as the Kuttner tumor. This is what we call as the Kuttner tumor. So it's a Kuttner tumor. It is chronic sclerosing. This is nothing but chronic sclerosing. It is the chronic sclerosing Sialadenitis. It is chronic sclerosing Sialadenitis of submandibular gland. And that occurs because of multiple stones, and then we call it as the Kuttner tumor. It is what we call as the Kuttner tumor. So whenever you have the sialolithiasis, in terms of investigation, the first investigation that I would perform would be an ultrasound. I can also perform the X-ray, as 80% of them are radio opaque. But if I say what is the investigation of choice, then it is going to be the NCCT of the head and neck. It is the NCCT of the head and neck which will become the investigation of choice. Now, when they say what is the gold standard, the gold standard or the best investigation is going to be the sialogram, which is also called as the sialography. Also called as the sialography, right? So the first investigation is going to be ultrasound. The investigation of choice is going to be NCCT, and the best investigation or the gold standard is what we call it as the sialogram, or also called as the sialography. Now, how do we manage? And this is going to be a very, very important protocol-based approach that we're going to create across, right? So talk about the management. We'll talk about the management of stones in submandibular gland. In the submandibular gland. We'll talk about the management of the stones in the submandibular gland. So I'll talk about the management of the stones in the submandibular gland. The first thing that you have to see where exactly the stone is present, right? So we'll try to categorize on the basis of where exactly the stone is present. Is it a distal stone? Is it a proximal stone? Or if the stone is not visualized on endoscopy, right? So we'll say whether it is a distal stone, whether it is a distal stone, whether it is a proximal stone, whether it is a proximal stone, or we can say if it's a non-visualization of stone. We say stones not visualized. Or if the stones are not visualized, right? So it is going to be either a distal stone or a proximal stone, or where the stones are not visualized, or the stones which are not visualized, right? Now, what is proximal? What is distal? Let's try to understand. Now you have the submandibular gland which is going to be present. So this is how the depiction of the submandibular gland is usually present. So this is the deep lobe and this is the superficial lobe. So there are two lobes of the submandibular gland that is present. So this is how the representation of the submandibular gland is present. Right. Now when you look at the duct which is present here, let's say this is the submandibular duct that is present, right? At this point, you have the lingual nerve, which is going to create a hairpin loop. So this is where the lingual nerve is going to go. Now, this lingual nerve, which is creating a hairpin loop around the submandibular glands duct, it divides the duct into two parts. The part of the duct which is present closer to the gland, this is what we call it as the proximal part of the duct. And the part of the duct which is present away from here, this is what we call it as the distal part. Now, this is what we call it as the distal part, right? So, this is what we call it as the proximal end. This is what we call it as proximal, and this is what we call it as the distal end of the duct, right? So, at this point, this is distal, and at this point, this is called as the proximal. So, you have the proximal and the distal. So, this is the submandibular gland. This happens to be the submandibular gland. Now, in the submandibular gland, this is submandibular duct. In the submandibular duct, this is the lingual nerve. This happens to be the lingual nerve. Now, this lingual nerve is creating a hairpin loop. This lingual nerve is creating a hairpin loop. Before this is called as proximal, and after this is what we call as distal. So, we say whether the stone is present in one of these locations or not, right? Right. So, we see if the stone is going to be present. Let's say the stone is present here. This will be a distal stone. If the stone is present here, this will be a proximal stone. So you have the proximal and the distal stone. This is the distal stone, this is the proximal stone, right? Now, if you have a patient with a distal stone, if the patient is having a distal stone, we'll see the size of the stone, whether it is less than 5 millimeters, whether it is less than 5 millimeters, or if it is more than or equal to 5 millimeters. Is it less than 5 or more than or equal to 5 millimeters? If it is less than 5 millimeters, if it is less than 5 millimeters, then we'll do an endoscopic. Then we'll perform an endoscopic removal of the stone. Endoscopic removal of stone, and for the stone removal, we'll be using a Dormia basket. We will use the Dormia basket for the stone extraction. We will use the Dormia basket for the stone extraction. If it is more than 5 millimeters, then we have to do a duct slitting. If it is more than 5 millimeters, then you have to do a surgical extraction. We have to do a surgical extraction of stone, and we do it by slitting the duct open. So here we do a duct slitting. We'll do a duct slitting. Now, duct slitting, I'll open the duct in a longitudinal fashion, remove the stone and resuture it back. As simple as that. Now, sometimes it is not possible to extract the stone either ways. If you are unable to extract the stone, if you are unable to remove the stone, if you are unable to remove the stone, this is what we call it as the impacted stone. It is what we call it as an impacted stone, a stone which is not easy to remove, right? For this, you can go ahead with ESWL, that is extracorporeal shockwave lithotripsy. Thus, we do an ESWL with transoral duct slitting, transoral duct slitting with stone extraction. So once you remove the stone, we suture the duct back with a 5-0 absorbable. We use a PDS suture material. What is the duct slitting is, if you are still wondering, if this is how the submandibular glands duct is present. And imagine if there are stones which are present here. These are the multiple stones we have to remove it. So what we do is we slit the duct in a longitudinal fashion. So I'm going to do a slit the duct in a longitudinal fashion. And once I give this incision, you will now open up the duct in this particular fashion. So this is how the duct is opened up. Now once the duct is opened up, I'll extract the stone, and once the stones are extracted, I will now suture it back. This is called as duct slitting technique of stone extraction, and then you'll resuture with an absorbable suture material. Usually we use a PDS suture material to finish it off, right? So this is if it is a distal stone, and this is how you're going to look at the entire protocol. So this is the protocol for the entire distal stones which are available. One second, guys. Right. So this is for your distal stones, right? Now, if there is a proximal stone, then what will you do? The proximal stone can be inside the parenchyma also, or it can be at the level of hilum also. So what we do is, again, we categorize on the basis of the presentation of the size itself. Now we see here the demarcation is taken at 7 millimeters, right? So you see if the stone is less than 7 millimeters in size, or whether it is more than or equal to 7 millimeters in size. If it is less than 7 millimeters, then we'll go with endoscopic removal of the stone. We do an endoscopic stone removal. Endoscopic stone removal with Dormia basket. With the Dormia basket. When it is more than or equal to 7 millimeters, then you do a transoral duct slitting. We use a transoral duct slitting technique for stone extraction. We use a transoral duct slitting for the stone extraction. For the stone extraction, if it is less than or equal to, more than or equal to 7 millimeters in stone. Clear? Now, if the stones are not visualized, if the stone is not visualized, this is on endoscopy. On endoscopy, if the stones are not visualized on endoscopy, that is, you've done duct endoscopy, here you'll try to identify by doing a trial ESWL, that is extracorporeal shockwave lithotripsy, and then try to localize it. Now, this is how you will determine your entire protocol for your stone extraction. So this is a very important topic. How do you manage your sialolithiasis, distal stones and proximal stones? Remember, the injury or the chances for injury to the lingual nerve is quite higher. So hence we don't prefer doing it on an often scale. Okay? Chalo. Now, what are the complications associated with submandibular gland excision? There's also a short note that can come. We talk about complications. Complications associated with submandibular gland excision. Now, the complications associated with submandibular gland excision. For any surgery, the common ones are going to be hematoma formation, seroma collection, wound infection. So hematoma formation, seroma collection, wound infection, all these are common. Apart from that, it is associated with the nerve injuries. Number one, it is associated with the marginal mandibular nerve injury. Marginal mandibular nerve. It's a marginal mandibular nerve injury. Another one is going to be the lingual nerve injury. Then you have the hypoglossal nerve injury. Hypoglossal nerve injury, an injury to the nerve to the mylohyoid. We call it as the mylohyoid nerve injury. It's a mylohyoid nerve injury. So there is hematoma, seroma collection, wound infection. Marginal mandibular nerve, lingual nerve, hypoglossal and mylohyoid nerves are the four nerves that can get injured in this particular component. Right. So this is with respect to submandibular glands excision. This is with respect to submandibular glands excision. Right. Now, we'll talk about the few important tumors that are present in the salivary glands, which are going to be important. Quick recap on the pleomorphic adenoma. We'll talk about the pleomorphic adenoma. So when I say pleomorphic adenoma, the word pleomorphic means multiple morphology, that is multiple shapes. So multiple forms are present. Now, what are the multiple forms? It can present to you as the epithelial component. It can present to you as epithelial component or the epithelial cells. It can arise from the epithelial cells. It can arise from the muscle cells. It can also arise from the cystic space. It can arise from the cystic space as well as from the cartilage. So epithelial cells, muscle cells, cystic spaces and the cartilage. That is a multiple forms. The word adenoma means glandular tumor. Adeno means glandular, oma is tumor. So it is a glandular tumor. This is your glandular tumor. So when you have multiple forms, so it can be a combination of any of the following. So this is going to be a mixed tumor. It's a mixed tumor that is going to be originating from the glands. So hence it is called as a pleomorphic adenoma. This is what we call as pleomorphic adenoma. Now, just for the sake of understanding, remember pleomorphic adenoma happens to be the most common. This is the most common benign tumors of salivary gland. This is the most common benign tumor of the salivary gland and the most common site. The most common site, it is going to be the parotid gland. The most common site is going to be parotid gland. Approximately 85% of the entire pleomorphic adenomas will be arising from that of the parotid gland. It is going to be arising from the parotid gland. So, talk about the clinical presentation of the pleomorphic adenoma. In the clinical presentation of the pleomorphic adenoma, number one, the age of the presentation is going to be around 30 to 60 years, usually seen in 4th to 5th decade of life. It is more common in females when compared to males. The ratio is 3:1. The ratio is 3:1, right? How will they present to you? Their presentation is usually of painless swelling in parotid region. There is painless swelling in the parotid region and they'll be gradually increasing in size. This would be gradually increasing in size. It will be gradually increasing in size. Now, based upon the location from where it is going to arise, you can have specific symptoms also. Now, we take this as a representation of the parotid gland. This is superficial lobe. This is the deep lobe that is going to be present. Now, if the tumor arises from the superficial lobe and if the tumor arises from the deep lobe. Now, if it is going to arise from the superficial lobe, let's say this is the superficial lobe and this happens to be the deep lobe. We all know the division is because of the neurovascular component that we have. Now, if the tumor arises from the superficial lobe or is it arising from the deep lobe? If the tumor is going to arise from the superficial lobe, then it is going to associate with dysphagia also. This will be associated with dysphagia. Sorry, if it is arising from deep lobe, it will be dysphagia, not for super. From the superficial lobe, usually the most common site for the tumor to arise is going to be the superficial lobe and that too inferior pole. So it is the inferior pole. It is the inferior pole of superficial lobe. Inferior pole of the superficial lobe is the most common site. If the tumor is arising from the deep lobe tumor or the deep lobe is associated with dysphagia. It is associated with dysphagia also because it is going from the inner side. It compresses the pharynx as well, right? Now, obviously, there is swelling in the parotid region. Usually, they don't have any other specific symptoms. Only the swelling in the parotid region is going to be present, right? So, you would like to examine it. You will call the patient for examination. So, what are the findings on examination? Now, on examination, number one, there will be swelling in the parotid region. There will be swelling in parotid region. Now, how do you know it's a parotid swelling? As the swelling increases, it's, this area which is called as retromandibular groove, the swelling occupies this area. You will not be able to feel the retromandibular groove. So, it's called as obliteration. There is obliteration of retromandibular groove. There's an obliteration of the retromandibular groove. The earlobe will be pushed upwards. So, earlobe is raised. Earlobe is going to be raised and it will be associated with the curtain sign positive. It is going to be the curtain sign positive, right? So, what is the curtain sign positive is? You can see that the gland which is present will move in this particular direction, that is in the anterior posterior, but it won't be able to go up because there's a curtain rod here, that is zygomatic arch, and your investigative deep cervical fascia is like a curtain, is arching down and not allowing the gland to move above this level. So when you try to move this gland, it will move in the anterior posterior direction. It won't be able to move up because the your zygomatic arch is preventing the gland from moving up. So this is what we call it as the curtain sign positive. It is what we call it as curtain sign positive, and skin over the swelling is pinchable. skin over the swelling is pinchable. The skin over the swelling is going to be pinchable. So swelling in the parotid region, obliteration of submandibular groove, the earlobe is raised, the curtain sign is positive, and skin over the swelling is pinchable. All this goes in favor of your salivary, it's a parotid gland growth basically, right? Now, when I say what is the investigations that you can do, number one, you can do the ultrasound of the parotid region. Number two, you can also perform the FNSE that is present, right? One specific feature is if there's involvement of the deep lobe. If there is involvement of the deep lobe on examination, what are you will find? Number one, you will see the swelling is present on the lateral pharyngeal wall. So swelling in lateral pharyngeal wall will be there. Swelling will be present in the lateral pharyngeal wall. Uvula will deviate to the opposite side. Uvula deviated to opposite side. Uvula is deviated to the opposite side, and this is if the superficial lobe is also involved. If the superficial lobe is also involved along with deep lobe, this is what we call as dumbbell tumor. This is what we call it as the dumbbell tumor, right? Now, how do you manage it? If I say what is the investigation of choice? The investigation of choice for pleomorphic edema or any parotid growth is going to be CECT of the head and neck region. It is the CECT of the head and neck region, right? Now, how do you manage the pleomorphic adenoma? The management of the pleomorphic adenoma. The management of the pleomorphic adenoma depends upon whether it is involving the superficial lobe or whether it is involving the deep lobe. Whether it is involving the superficial lobe, whether it is only involving the deep lobe, or is it involving like a dumbbell tumor, where it is involving both superficial and the deep lobe. If it is only involving the superficial lobe, then you have to do a superficial parotidectomy. Then you have to perform a superficial parotidectomy. You have to perform a superficial parotidectomy. If it is a deep lobe, then you have to perform a total conservative parotidectomy. When I say conservative, you preserve the facial nerve. Dumbbell tumor also, you'll do a total conservative parotidectomy. You'll do a total conservative. You'll perform a total conservative parotidectomy. It depends upon where it is involved and how you're going to do across. This is how you do about your pleomorphic adenomas, right? Now, this is with respect to the parotid surgeries as well. Now, couple of important things about the parotid surgeries. So, we'll quickly give a short note on the parotid surgery also. Now, in the parotid surgery, number one is the incisions that you should know. What are the incisions that you're going to take? The first incision that you have is your Blair's incision. The first one is your Blair's incision. Then you have the modified Blair's incision. We have the modified Blair's incision. The modified Blair's incision is also called as the lazy S incision, also referred to as the lazy S incision. also referred to as a lazy S incision. Then you have the face lift incision. Then you have the face lift incision. So you have the Blair's, the modified Blair's, and the face lift incision. These are the three incisions that you have. Now you might be wondering what are these incisions. Let's quickly run through them also. Now, if you take this as the representation of the patient, this is the neck that is present, right? Now, this is the orbit, this is the zygomatic arch, right? Now, what is a Blair's incision? What is a modified Blair's incision? Let's try to understand. If the incision is going to start in front of the parotid region, I'll make it simple, wait. Right. So this is how the objective is going to present. If the incision starts here and then it goes behind, the ear. It starts here and goes behind the ear. This is what we call it as the Blair's incision. Same incision if it starts like this and then it goes and then it continues like this. This is what we call it as the modified Blair's. Modified Blair's is also called as a lazy S incision. This is called as a lazy S incision. Then you have an incision which is going to start in front, go behind, and then continue across the ear, which is going to be like this around the crease. This is what we call as the facelift. This is your face lift incision. So Blair's, modified Blair's, which is laziest, and then your faceless incision. There are three incisions that are going to be present. Now, once you're given the incision, how do you identify the facial nerve? Identification of the facial nerve, or also called as the facial nerve localization. Also called as the facial nerve localization. To give a facial nerve localization. Now, how do you localize the facial nerve? So, look at the facial nerve localization. The first one that you have is what we call it as the tragal pointer. The first one that you have is a tragal pointer, or also called as the Conley's point. Also called as the Conley's point. Now, what is a tragal pointer or Conley's point? You identify the tip of the tragal cartilage 1 to 1.25 centimeters, medial and below. So, we call it as a tragal pointer or the Conley's point. It is defined as 1 to 1.25 centimeters, medial and below. Medial and below the tip of the tragal cartilage. Tragal cartilage is where you will find the trunk of the facial nerve. This is called as a tragal pointer. Another identifying part is the superior surface. It can be traced on the superior surface. The superior surface of posterior belly. Superior surface of the posterior belly of the digastric muscle. Or the digastric muscle. Then you have the tympanomastoid sutures. Tympanomastoid sutures, inferior to suture line. Inferior to the suture line, you will find the trunk of the facial nerve. So these are the three sites where you can localize the facial nerve. Number one is tragal pointer, another superior surface of the posterior belly of the digastric muscle, and the tympanomastoid sutures. And the tympanomastoid sutures, these are the sites that you can see across here, right? Now, what are the complications that you can see often with the parotid surgery? Now, the complications that you can see post-parotid surgery. So we got post-operative complications. We have the post-operative complications. The post-operative complications associated with parotid surgery. The post-operative complications. The post-operative complications which are associated with the parotid surgery. So look at the post-operative complications. Number one, it is going to be the nerve injury. So what are the nerves that can be injured in a parotid surgery? Number one is your marginal mandibular nerve. It is the marginal mandibular nerve. It's a the marginal mandibular nerve. If there is injury to the marginal mandibular nerve, there will be drooping of the angle of the mouth. There will be drooping of angle of mouth. Then you have injury to the greater auricular nerve. Injury to the greater auricular nerve, which will result in anesthesia. Which will result in anesthesia at the angle of mandible and the earlobe. At the angle of the mandible and the earlobe. And the earlobe. And the last one is injury to the facial nerve. Injury to the facial nerve. So these are all the injury statuses that are going to be present with respect to nerve injuries. Apart from nerve injuries, it is also associated with post-operative hematoma, flap necrosis, secondary infections, deformity of the face, that is cosmesis deformity. One thing that is going to be important is going to be Frey syndrome. Frey syndrome is also called as gustatory, sweating, also referred to as the gustatory sweating. And the last one that you have is your sialolithiasis. So these are the post-operative complications that you will see after the parotid surgery. After the parotid surgery, these are the post-operative complications that you will be able to visualize. Now, what I would like to talk upon is going to be on the Frey syndrome. So we'll talk about the Frey syndrome. Now, when you talk about the Frey syndrome is also called as the gustatory sweating, also referred to as the gustatory sweating. also referred to as the gustatory sweating. Now, let's try to understand that what is Frey syndrome and how Frey syndrome is going to kick in. Now, to understand this, let's keep it very simple. Let's take, this is the representation of the mandible which is present here, and the skin is covered on this area. And then you have the parotid gland which was present here. So this is the area where the parotid gland was present. This is the area where the parotid gland is present. So that is in front of the mandible, right? This is the basic objective that you have. Now, just to give you an objective, this parotid gland is supplied by both sympathetic and the parasympathetic nerve supply. So let's take this as a representation. I have one which I will call it as the salivary nucleus which is present. Another one will take it as the sympathetic ganglion chain. Another one that you have is your sympathetic ganglion chain. Now, from the salivary nucleus which is present here, from the salivary nucleus, which is also the parasympathetic nucleus, or I can say the parasympathetic supply, this salivary nucleus which is present, which is also called as the parasympathetic component, it will give rise to a nerve. Now, this nerve that is going to arise from here is what we call it as the glossopharyngeal nerve. Now, this glossopharyngeal nerve is going to pierce the tympanic membrane. So, this is where you have the tympanic membrane that is present. So, this glossopharyngeal nerve will go through the tympanic membrane. It will pierce the tympanic membrane, and then it will relay onto a ganglion. The ganglion on which it is going to relay on is what we call it as the otic ganglion. From the otic ganglion, it will now start to relay down the parasympathetic nerve fibers. So, the parasympathetic supply to the parotid gland is going to come in this particular manner. Whereas the sympathetic nerve fibers are going to arise from the sympathetic ganglion, and this sympathetic ganglion is going to supply the nerve fibers to that of the parotid gland, right? So, this is your sympathetic system. This is your sympathetic system, right? So, you have the salivary nucleus. This is your glossopharyngeal nerve. This happens to be the glossopharyngeal nerve which is present here. This is what we call it as the glossopharyngeal nerve. This is what we call it as the glossopharyngeal nerve. This is the tympanic membrane. This is the otic ganglion. And this nerve which is arising from the otic ganglion, this is your auriculotemporal nerve. This is what we call it as the auriculotemporal nerve. Now, the auriculotemporal nerve supplies the parasympathetic, sympathetic ganglion supplies the sympathetic flow, right? So, this is the basic objective that is present, right? Now, today we are going to do what? We are going to do a superficial parotidectomy. So, what I have done is I am now going to remove the parotid gland. Now, as I am removing the parotid gland, you can see that there could be an injury to the both sympathetic and the parasympathetic nerve fibers, right? So, what is going to happen? Now, over a period of time, once you have removed the gland, after 2 to 3 months, what is going to happen? Everything remains the same. This is the mandibular status that is present. This is the area where the parotid gland was present, and you have removed the parotid gland, which is going to be here, right? We're not going to change anything. Everything remains the same. So, we say this is the salivary nucleus that is present, which is here. This is the sympathetic nerve or the ganglion that is present here. From here, we know the nerve is going to arise. The nerve arising is what we call it as a glossopharyngeal nerve. This is going to pierce the tympanic membrane. Once it pierces the tympanic membrane, it is now going to go and relay onto the otic ganglion. From the otic ganglion, it is going to give rise to the nerve fibers, which is called as the auriculotemporal nerve. And this auriculotemporal nerve is supplying the parasympathetic nerve fibers. Now, this is injured. During the surgery, these nerve fibers of the auriculotemporal nerve is going to get injured. So you see the auriculotemporal nerve is now being injured, and this is going to be present across here. So this is going to re-innervate and this is going to regenerate. Now this re-innervation will now going to cause innervation onto the overlying skin surface. At the same time, you see the sympathetic nerve fiber which are going to present here. They were also injured, so they will also re-innervate and regenerate. But during that re-innervation, they will have cross-innervation among themselves, and they will also innervate to the overlying skin that is present. So because this cross-innervation, what is going to happen? Every single time the salivary nucleus that is present here, every single time the salivary nucleus which is going to get stimulated, which is the parasympathetic driver, when it stimulates the auriculotemporal nerve. Now this auriculotemporal nerve, when it gets stimulated, it will stimulate the otic ganglion. Now once the otic ganglion is going to be stimulated, the auriculotemporal nerve is going to get stimulated. Problem is, the minute the auriculotemporal nerve is stimulated, it should only stimulate the parasympathetic pathway, but because of cross innervations, every single time the flow is present here, it will now going to cross onto the sympathetic one, and then it is going to cross innervate. So what is happening? Every single time I see, initially when I was turning the switch on here, only the current was flowing here. If I was turning the switch here, which is the sympathetic pathway, this is your sympathetic ganglion. Now, if I turn the switch on, the current was passing here and they were individually working. Here, every single time I stimulate the salivary nucleus, it goes and stimulates the parasympathetic pathway because of cross innervation. Together, they're going to stimulate the overlying skin. Same way, if I stimulate the sympathetic pathway, it cross innervates, stimulates the parasympathetic, and also causes the parasympathetic drive. So this cross stimulation. So if I'm turning the switch on here, rather than only turning on this light, that light is also getting turned on. If I turn on this light, rather than turning this light along with this light is also getting turned on. So it's a cross innervation. The current is flowing because दोनों के बीच की जो तार है ना, वो ऐसे इंटरसेक्ट हो गई है. ठीक है, तो एक जगह ऑन करता तो दूसरी जगह भी ऑन हो जाता है, एक दूसरी जगह ऑन करता तो ये भी ऑन हो जाता है. This cross innervation is what we call it as the Frey syndrome. So this cross innervation will occur after 2 to 3 months. So this is after 2 to 3 months of surgery. This can occur after 2 to 3 months of the surgery, right? So after 2 to 3 months of the surgery, right? So after 2 to 3 months of the surgery, it will result in cross innervation between the parasympathetic and the sympathetic pathway. Between the parasympathetic and sympathetic pathway. Now this results in it relays onto the overlying skin. Onto the overlying skin. So what is going to happen? Every single time the patient is going to consume food, when the patient is going to start eating, it is now going to cause the parasympathetic stimulus. Now, normally the parasympathetic stimulus should take away the parasympathetic pathway, but because of increase in parasympathetic activity on food, so it will now going to result in two things. More amount of blood will flow to the skin, so hence there will be increase in sweating. There will be increased sweating and it will be associated with pain. Now, every single time the parasympathetic pathway is going to get stimulated, it will also stimulate the sympathetic pathway. Now, when the sympathetic pathway is going to get stimulated, it will now result in excessive blood flow to the overlying skin, resulting in erythema. So, with every single time the patient starts eating, the parasympathetic pathway gets stimulated, but rather than going onto the parasympathetic flow where it has to increase secretion of the gland, now because it is innervating the skin, it increases the secretion in the skin, which is nothing but sweating, and obviously that excessive stimulus will cause pain also. Sympathetic pathway is known to cause excessive drive of blood. Now here the blood flow to the skin will increase, causing erythema. So you have increased sweating and the redness, that will say flushing will be there, that is erythema, and increased sweating in that area. This is what we call it as the Frey syndrome is going to be present. Now, how do you do it? In order to conclude the diagnosis, the investigation of choice. The investigation of choice is going to be the starch iodide test. It is the starch iodide test. So what do you do is, I'm going to put the iodine solution here and then put a starch. That white powder will be there. Then I'll ask the patient to eat and the sweat will come across. Wherever they cross innervation, their sweating will occur. There you will have the discoloration, right? So if there's presence of, on starch iodide test, there will be presence of bluish discoloration over the starch powder. And that is the area of cross innervation. So this bluish discoloration corresponds to the area of cross innervation. This corresponds to the area of cross innervation. So now you have localized the area of cross innervation. So once you have identified the area of cross innervation, the management is going to be straightforward. How do you manage this condition? The management is going to be, number one, I am going to inject botulinum toxin. Inject botulinum toxin in the discolored area. In the discolored area. If this phase, the second line that you have is your Jacobson's. It is your Jacobson's tympanic neurectomy. The Jacobson's tympanic neurectomy. You perform Jacobson's tympanic neurectomy, right? In the Jacobson's tympanic neurectomy, I am going to ligate. This is also called as the preganglionic neurectomy. Is also known as preganglionic neurectomy. What is this preganglionic neurectomy is? If you see, this is the salivary nucleus. From the salivary nucleus, you see the nerve is going to go. It is going to pierce the tympanic membrane. After piercing the tympanic membrane, it will now relay onto the otic ganglion. From the otic ganglion, it will now release your nerve fiber. This is your auriculotemporal nerve. This is your auriculotemporal nerve. So before it goes onto the ganglion, we are going to do a neurectomy, right? So usually neurectomy is done at the level of the round window. So I will excise the nerve here. Now because I'm excising the nerve before the ganglion, this is the otic ganglion. So before the ganglion, I'm doing a neurectomy. It is called as preganglionic neurectomy. This is what we call as a preganglionic neurectomy. Now, does every patient of the superficial parotidectomy, will they develop Frey syndrome? The answer is no. How do you prevent them? It's a preventable component. So how do you prevent the Frey syndrome? To prevent the Frey syndrome, how do you prevent the Frey syndrome? To prevent the Frey syndrome, number one, you can use a muscle flap to cover the underlying skin area. Usually we can use the sternocleidomastoid muscle. You can also use the temporal muscle flap. You can also put artificial membranes. Also put as artificial membrane. You can also put an artificial membrane. So you can use the muscle flap. You can use the temporal muscles and the artificial membranes. Right? So these are the components how you can prevent the Frey syndrome. So these are the important aspects with respect to the salivary glands. The basic anatomy is important. We have discussed that also. So in the parotid glands, the anatomical orientation is very important. How do you differentiate the superficial and the deep lobe? What is this fasciovenous plane of Patey's? What are the nerves? And see, The order is important. The first is artery, that's the external carotid. Then you have retromandibular vein, and the last one is a facial nerve, right? So the order is important. We have to remember that. Then the relationship of the submandibular gland and its surrounding structures. What are the various nerves that you will see? Three important nerves: marginal mandibular nerve, hypoglossal nerve, lingual nerve, which is going to cause a sling fiber around that, is also equally important. Then you have what is the reason for more probability of development of stones in the submandibular gland. I've given you in a quick recap also. Two topics which are frequently asked. Number one is sialadenitis, that is the inflammation of the salivary glands. We've tried to talk about the salient features, especially in the parotid gland abscess. Then sialolithiasis, very, very important, asked repeatedly. How do you manage the salivary gland stones? And this is how the sialolithiasis is going to look across here. The management is also important. Remember, how do you differentiate between the proximal and the distal stone? That itself is an important aspect. Proximal is like closer to the gland, distal is away from the gland. So lingual nerve is the landmark. Before lingual nerve, it is proximal. Away from lingual nerve, it's called as distal stone. The management of proximal and distal stones are important. Just give a quick recap to that as well. Complications of submandibular gland excision has been asked in our exam as well. Then you have pleomorphic adenoma, which is also asked again and again. So pleomorphic adenoma, what is done? What is the objective? How do you manage it? If it is in the superficial, deep, and both the lobes. Parotid surgeries, incisions are important. Blares, modified blares, and facelift incision. And then what are the possible nerve injuries? What are the post-operative complications? And more importantly, what is your Frey syndrome? Frey syndrome has been asked again and again. The basic concept of Frey syndrome, I've tried to explain you. How do you treat Frey syndrome and how do you prevent Frey syndrome? Both of them are also equally important, right? So this is all in all with respect to the salivary glands that you're supposed to know, right? Chalo. So, is there any questions that you would like to ask? Quick feedback. All right, guys, if there is nothing else, that's it for today. Thank you so much for joining. If you have any questions, you can ask. I'll share the PDF soon after the class as well. Until then, bye. Take care.